what sort of sexual dysfunction can PT for the pelvic floor help with?
Primarily, the things that we address with sexual dysfunction are pain. Now, whether that's pain with penetration, whether it's vaginal penetration or anal penetration, pain with orgasm in either, in any gender, pain with erections, pain with ejaculation. So pain is probably the biggest issue that we address in, again, any genders when it comes to sex. Now,
Oh, okay.
certainly some of the other pain issues that maybe someone doesn't have pain with sex per se, but they have, chronic abdominal pelvic pain because of fistulizing disease or whatnot, and just the ramifications that can have on just muscle tension in this area, not feeling desirable, having, a low libido as they don't feel good. So of course they're going to have a low libido.
Right.
And so even indirectly, if it's not specific, sex related pain, but we know that the impacts of those other types of pains or dysfunctions will impact their sexual beings. If we address their pain or their incontinence, because sometimes it's a fear of being incontinent or something like that during intimacy, that can lend people to get different muscle dysfunctions, whether we're directly treating the problem of pain with sex or something related to it, those are all things that we can address. Sometimes too, because muscle control is involved with orgasm, sometimes orgasm function can be improved. Obviously, orgasm is a very multifaceted entity that can have neurological inputs, vascular inputs, brain inputs, as well as muscular inputs that we can't always promise that, orgasm will absolutely be improved, but sometimes because of all the other work that we're doing, it can be.
I know that some people experience anal prolapse, vaginal, rectal fistulas. So can you talk to us a little bit about maybe some of those things and other issues that people present with?
Absolutely. And so some unique things with people who have IBD, typically like a very classic pattern, if you will, is kind of what you were describing even with yourself. When you have IBD and there's this constant urgency, frequency, particularly of loose stools, you never know where the bathroom is. And those muscles very quickly learn how to clench.
Mhm.
And because again, inherently these muscles are postural, they pick up on that habit and that becomes your new posture. And when we have tension in the pelvic floor muscles, and we kind of look at the anatomy again, so when these muscles contract, they're going to close off the urethra, the vagina, and the anus, or the urethra and the anus in males. And so when there's tension there, that can make elimination more difficult. So when you do finally go to the bathroom to urinate, to defecate, to pass gas, or you want to relax your muscles to allow penetration to happen, whether sexual or not, those muscles are likely not going to be able to let go. And therefore, it's going to inhibit your ability to have pain-free penetration, to potentially evacuate your bowel and bladder fully, which could then lead to symptoms like constipation, fecal incontinence, urinary urgency frequency, incomplete urinary emptying. And so it's very common that even if someone, again, like presents to the clinic with, oh, I'm really having a lot of pain with penetration, when we ask further questions, because these muscles have shared functions with all of these different orifices, we often see overlapping conditions. So somebody who's really clenching tight because of urgency frequency of defecation likely also has urgency frequency of their bladder and potentially pain with penetration or just pelvic pain in general. So that's a very common presentation. But then again, going back to specific IBD related issues, if there is fistulizing disease, and now we have a lot of, perianal skin pain and issues, abscesses, breakdowns, again, all those things can cause pain. And whether it's the skin or the wound, that's really the painful entity. Because these muscles are in close proximity to that, when we're in pain, our body clenches or contracts to kind of protect us, if you will. But unfortunately, the longer it stays in that clenched position, even if we heal the skin and disease is in remission, it's not like the muscles get that memo. So those muscles can still be propagating a certain amount of pain, and it's not addressed until we go in and actually focus on the muscle that's just not letting go.
Right. And so then so then people with an ostomy. So some people with ostomies still do have their rectum
Mhm.
and anus there. Some of us have it removed. But I would presume that you can still have PT done. Like it doesn't make any difference because you have a an ostomy. Would I be correct in saying that?
You are absolutely correct. And you bring up a great point because certainly, like you mentioned, some of my patients with ostomies still have their anus, they still have their vagina. But plenty of people I've seen no longer have an anus, or they've had to have a vaginectomy because of cancer or other kind of radical surgeries, whether it's disease progression from IBD or some other issue such as cancer. And so, for the most part, except in some very extreme cases, the pelvic floor muscles are still there. And so that can be helpful or not helpful depending on if those muscles are also causing dysfunction. And so, plenty of cases we can't do an internal exam, but there's often still work that we can do externally to assess the muscle function and to, again, work with whatever scar tissue or fibrosis could be there to improve someone's function, assuming that they're having some kind of dysfunction.
Right. And then would you say, because I have an ileostomy, so the rectum has been removed. So like everything feels different, even when I go to see my GYN, like, the cervix is in a different position. Everything feels differently because you don't have the rectum there for that little extra padding. So do you see a lot of dysfunction then when people have that removed?
So not necessarily, to be honest, and whether that's a manifestation of, usually I see people at particular points in their life, versus like seeing someone over the course of like their disease progression for 10 years or what have you. But in the experience I've had in the last 20 years, usually, just having a particular anatomy part removed isn't usually the dysfunction. And because that particular anatomical part has been removed, it's usually a positive thing because having had that particular organ there was causing more dysfunction. And maybe I wasn't there with them prior to when that was actively causing dysfunction. But it really kind of depends on every individual's specific presentation. And so certainly sometimes having loss of anatomy can present in certain dysfunctions. Usually the dysfunction that I'm seeing them for is unrelated to that per se, because the fact that that piece has been removed has really enhanced their overall function in other ways.
That makes a lot of sense, actually. Yeah. Yeah. My name, as I said, is Elaine O'Rourke. Please go to my website if you are struggling in any way. I help people with the mental, emotional issues of having an ostomy, of having Crohn's, having colitis, and really help people get back on their feet again. So my website is elaineo'rourke.com. You can grab your free guide, 3 ways to eliminate fears about your ostomy, or your free guide for Crohn's and colitis, about 5 mistakes even well-informed people make with IBD. Please follow me on YouTube. You can subscribe there as well. That is really helpful. And my new Instagram page is Ostomy IBD Life, and it's the same name on Facebook.